Hello and welcome. My name is Fiona Charlton, President of ANZMES, the National Advisory for Myalgic Encephalomyelitis, chronic fatigue syndrome, and associated conditions here in Aotearoa, New Zealand. Today on World ME Day, May 12, we're honoured to be joined by our special guest, Jaime Seltzer, who is here to bust myths with facts. Jaime Seltzer is Scientific Director at ME Action, Time 100 Health Honoree, and affiliate researcher with Stanford University. Jaime is leading groundbreaking projects in ME/CFS, long COVID, and infection-associated chronic illnesses. So welcome, Jaime. Thank you for joining us here today. Really
Thank you so
appreciate
much
it.
for having me. It's a pleasure to be here.
To kick things off, would you like to share a little bit about yourself? Perhaps tell us about your career and advocacy work and what drives your passion for researching and raising awareness for ME/CFS and long COVID.
Absolutely. So I live with ME/CFS myself. After COVID, I did have some new symptoms that have lasted a very long time. I don't necessarily use the long COVID label because I do feel that's a unique experience. But I definitely did experience those long-standing issues. The thing that's most important to me is that this disease runs in my family. At this point, we have an infection-associated chronic condition diagnosed in my mom, my older sister, me, my niece, my first cousin, my third cousin, and my best friend since childhood, even though we're not related. So it seems to be that this disease has transformed the lives of the women who are most important to me. And I knew that this was what I wanted to do from a pretty young age in a kind of different sense. My mom was sick when I was very young, and I decided to go into pharmacy and then alternative medicine because doctors had no answers for her. And that training ended up allowing me to be as functional as you see me today. I didn't know I would get it. All of us got it at about the same age, not necessarily at about the same time. I was at ME Action first as managing editor, but I began to attend scientific conferences and do some translational work in terms of taking the scientific work and making it digestible for the community. And then I was hired out of the IACFS ME conference to work at the Stanford Genome Technology Center under Ron Davis, and then came back to ME Action in the director role. Since then, I have produced the diagnostic and treatment algorithm for ME/CFS that's currently used at Mayo Clinic Rochester, along with a concise clinical review with them with some attendant medical education. And I feel as though the world of research had been opening up to people with infection-associated chronic conditions. And I'm involved in so many research projects I can't talk about yet. Many of them exciting, and none of them have lost their funding yet.
That's really good news. And thank you for sharing that. Obviously, your passion and integrity shines through. It's wonderful to have such vital work that going on, not only to better understand the conditions, but also so that we have high quality and robust research, which is vital for this condition, and that it's communicated effectively, which is what we hope to achieve today, just to counter that misinformation and bust those myths once and for all. And thank you for sharing about your family. And I hope that we can also touch on that a little bit more in the sense of who gets ME and that side of it, if you want to go into that a little bit more. But I think what would probably be helpful to start us off is if we go through a quick explanation of what ME/CFS is for those who may not know. So can you tell us what is ME/CFS?
Absolutely. So ME/CFS, myalgic encephalomyelitis, chronic fatigue syndrome, is an infection-associated chronic illness. That doesn't mean every case is triggered by infection, but infection precedes the majority of cases of ME/CFS. Other immunological and endocrinological stressors can also kick it off. And by the way, this is a pattern we see in a lot of other neurological diseases, so it's not unusual to see this onset pattern. It's characterized by a symptom set or a pathological state called post-exertional malaise, or PEM. Post-exertional malaise is when people experience a flare of symptoms and or the appearance of new symptoms after physical or cognitive exertion. And there's often, but not always, a characteristic 24-hour delay between the triggering event and onset of these symptoms. Oftentimes, the person wakes up the next day and can't sit up in bed. So it's quite dramatic. It's not like you feel a little bad. Different countries use different diagnostic criteria, but all of the modern sets of criteria have this pathognomonic symptom, PEM, at their core. We use pathognomonic to mean this is the symptom that identifies the disease. The diagnostic criteria that we use in the US also requires fatigue for 6 months or more, a significant loss of functional capacity, orthostatic intolerance and or cognitive issues, and so on.
Yeah, and I think that's the important thing to touch on is that post-exertional malaise is actually very debilitating and impactful on a person's life. Can you explain a little bit more about what someone might experience and then how they can recover from what we call a crash of PEM?
Absolutely. So post-exertional malaise, should say, we kind of hinted at this, right? It's very unique. If you're a healthy person and you're listening to this podcast, you haven't experienced anything like PEM, unless maybe you've had sepsis or shock. It is a pathological state where a lot of things are going wrong at once. So what someone might experience with that characteristic delay is an increase in the symptoms that are common in ME. So orthostatic intolerance, which is a worsening of symptoms when you go from lying down to sitting up or sitting up to standing. So you might feel dizzy and have other autonomic symptoms like trouble regulating your temperature. You might start to shake. And a lot of people feel a difficulty initiating movement, which is not the same as fatigue. It's like you try to move and you cannot quite do it. Cognitive impairment is also very common. People often call this brain fog. And one of the more common presentations is some minor aphasia where people cannot find the word that they're looking for. And this can be pretty profound for people experiencing it, even if the patient has a large vocabulary and can hunt around quickly for some other word than the word that they want. And so, if you don't know that you have ME/CFS and you're experiencing this, you might feel perfectly fine when you're going for a short bike ride. You might enjoy it. You get home, you go to sleep, you wake up the next morning, you hit about the same time of day, and you can barely move, you can barely speak, you feel terrible. There are flu-like symptoms like fever and lymph node swelling because there's some immune activation involved in PEM. So you get a lot of those I must have caught something symptoms kicking up. So it is pretty profound. The way that you manage that day to day is a symptom management strategy called symptom contingent pacing. That is, you're active when able, you rest when you're tired, you don't go over your limits. While some people who practice pacing may see their limits expand over time because they're not crashing over and over again, the goal isn't really to increase functional capacity in terms of to get well again. It's to experience less severe symptoms and to manage your disease. If you are in the middle of PEM, you must rest. You must rest. That is the number one intervention. And some people will do radical rest before a big exertion so that they are less likely to experience PEM afterwards.
Absolutely. I think that's what I hear in the community most often is that you have to plan your rest around an activity. So you rest the day or a couple of days before you have the activity, particularly if it's one outside of the home. And then there's rest afterwards, whether it's days, for some people it's weeks. So life becomes very short when you can only do one activity in a week because you're resting on either side of it just to make it happen. And I think that's something that healthy people don't realize because they see us at that point when we're out doing that event with them. They're not seeing the pre-rest and the post-rest. And usually, if we've overexerted and gone beyond that energy envelope, that post-rest is that debilitating event or crash, which we hope that with proper pacing, people will experience less and less. Is that right?
Less and less. It's definitely true that If you pace well, you crash less often. All the same, there are issues outside of your control. Some people feel a little bit worse before major weather changes. We don't really have control over that kind of thing. It's also important to mention that pacing involves breaking larger activities into pieces interspersed with rest. Someone with minor or moderate presentation may be able to have the same step count as a healthy individual, provided that they break their activities up with rest. I'll stop there. I don't want to go on too long. I can talk forever about pacing and pacing strategies. That is one of the studies that I'm processing the data now, and it's very exciting.
Oh, that's excellent. Can't wait to see it. I mean, it's the thing is, it can't be over discussed because it is the key aspect that we all need to learn. And I have not learned it, and I've been ill for 16 years, but I seem to keep
I
pushing
must
myself.
mention the pacing guide here. I'll pitch it. The ME Action Pacing Guide I developed at the start of the pandemic because I knew how many people would be coming down with an infection-associated chronic condition. It gives people the basics, so maybe we'll share that as part of our resources. I'll also say that there's a study that came out of my old lab, Ron Davis's lab, that inquired as to different interventions, and pacing was the #1 most effective intervention. And I don't mean management technique. I mean any intervention of any category, including pharmaceutical medications, pacing comes out ahead. So it's vital.
Absolutely. And yes, we will definitely share that resource. So is there actually a cure for ME/CFS? And, do people recover, or how many people are likely to recover?
Well, I want to interject that a lot of people use the word recovery to mean improvement, right? So do a lot of people improve? Yeah, a lot of people do improve. In fact, there is some evidence, both anecdotal and in the literature, that the first year and a half are very challenging for people. And thereafter, they come to a new baseline that is not as healthy as when they were well, but is not as sick as the first year and a half or so. And that may be because there's a hyperinflammatory pattern early on and a more immune exhaustion pattern later on. That's from the Hornig study out of Columbia University 2015 that showed inflammatory cytokines very high in the beginning and below average thereafter. So what's more comfortable, hyperinflammatory or mild functional immunocompromise? The latter is a lot more comfortable. So people improve. People also improve when they find medications, both over the counter and prescription, that work for them, when they learn how to pace. All those things are possible, and you can live a much better life than you are now if you're listening to this and you're early in disease, and or maybe you're learning about it for the first time and you really haven't been sure how to handle it. Improvement is always possible. Recovery is rare. A very old study by Carnes, I want to say 2005, talked about a 5% recovery rate in adults. That's, of course, before any of the modern diagnostic criteria existed. So if we're going by the National Academy of Medicine criteria, CCC or ICC, is probably a slightly lower percentage that we would say would recover who meet those criteria. Children appear slightly more likely to recover. However, they may relapse in adulthood. So it's very important that they still keep their eye out for signs of post-exertional malaise. There is no cure. And frankly, anybody who says more than what I just said, you can improve if you work at it, and there are medications that can help you, and there are over-the-counter things that can help you, and management techniques that can help you. If they tell you that they have a cure for this disease, you're about to be scammed.
Thank you. Yes, that's very important. So, how common is ME/CFS?
It is sure a lot more common than it was in 2019. Because ME/CFS is an infection-associated chronic condition that often follows a trigger that is a pathogen, often but not always a viral one, we've seen a lot of post-SARS-CoV-2 cases. So long COVID, right, is the name for any long-term sequelae after SARS-CoV-2 infection. About half of the people with that label at 6 months, they're still sick at 6 months, they then meet, about half of them then meet the diagnostic criteria for ME/CFS. a paper recently came out saying that the number of people with ME had increased 15-fold. I think that we have to take into account the passage of time and other factors, but I think it's quite accurate to say it has increased many-fold since the pandemic. You definitely know someone with ME/CFS, and you definitely know someone with long COVID, probably several someones. Before the pandemic, it was 0.5% of adults, about.
So who actually gets ME/CFS?
Good question. Anybody and everybody. I have thought that this was both pathetic and amusing. At the start of the pandemic, everyone with long-term symptoms was painted as elderly. This cannot be further from the truth. There are 2 spikes in diagnosis in ME/CFS, according to a very large-scale Norwegian study. And one of those spikes is in late childhood, early teens. And then the other spike is like late 20s to late 30s. So we see people really struck down either in childhood or in the prime of their life when they're just starting like their work life and just beginning to get to the job they like and maybe making a family. And it doesn't mean you can't contract it at other times. It means those are the 2 most likely times. And I will say it's significant. The curve looks like that. In childhood, it seems that boys and girls are about likely to get ME/CFS, but the second spike is much more common in women. So that means that the female prevalence of the disease is slightly higher, but men are probably underdiagnosed. And similarly, in terms of white people, more white and wealthy people get diagnosed because they have access to the diagnosis. But there are a handful of small studies that show that people who are Black, Indigenous, or people of color are slightly more likely to actually meet the diagnostic criteria. So yeah, this disease spares no one.
Yep, it spans genders, age, socioeconomic group, ethnicity.
Everybody.
It's not discriminatory.
No.
So you've mentioned that children get ME/CFS as well. So do they experience similar or the same symptoms to adults?
It's a good question. Slightly different because they're much more likely to have a common comorbidity. Well, one of 2 common comorbidities, one of which is POTS. POTS is postural orthostatic tachycardia. It's a difficulty in regulating blood pressure, usually when you change position, that causes a pounding of the heart, very common in young ladies. And the other is hypermobility syndromes like Ehlers-Danlos syndrome and other similar syndromes. In these hypermobility syndromes, lots of people live with those their entire life and they don't really have symptoms to speak of. But for other people, because it's a disease of connective tissue and connective tissues everywhere in the body, they have digestive issues, they easily dislocate their shoulder, their ankle, their wrist. So these 2 conditions are also infection-associated conditions. In the case of EDS, we have a clear pattern of heredity, so we say it triggers or unmasks EDS. That is, for some people, it's just not noticeable. It doesn't cause symptoms until after a viral infection, and then it sure does. So both of these are associated with ME/CFS, and we see them with concurrent ME/CFS in children more often. So the symptoms associated with those comorbidities are more likely to be primary symptoms in children and adolescents. Otherwise, it's the same disease and it presents the same way.
Can I just touch back on EDS? Because I actually saw on Reddit a health professional writing something very derogatory about EDS being a new popular diagnosis. And what's going on? There's all these people getting diagnosed with EDS since COVID. So do you want to
What a
touch on,
surprise.
yeah, exactly. Do you want to touch on a little bit about why that actually is happening?
Well, like we said, it is an infection-associated chronic condition. So you see people having problems with it for the first time, after they get a viral infection. I have had hEDS my whole life. It really did not bother me. It still doesn't bother me as much as the other things I've been diagnosed with. But I'm sitting here, you can't see, but my legs are completely folded, and this is the most comfortable way for me to sit. That's one of those ways that you can tell. People can take their thumb and pull it back, and all of those different things. If you can, as an adult, take the flats of your palms and press them on the floor leaning down, you're probably a little hypermobile. And again, it doesn't necessarily mean anything. It doesn't necessarily mean it's a pathology until it is. Until the stretchiness of you affects your gut and your digestion and your veins and your ability to tighten or loosen them and prevent yourself from passing out when you stand up. So yeah, we're going to see a lot more of these conditions. Guess what? We're going to see a lot more of all of them. We are.
That's right. That's right. And what it seems to be is that a lot of people who go on to develop ME/CFS do have some form of hypermobility that, as you've mentioned, hasn't been an issue. But then with the COVID infection, which we know the spike protein has been attacking a connective tissue, it suddenly becomes an issue. And it's
Well,
suddenly
lots of
people are,
viruses, by the way. Lots of viruses
yes,
attack collagen, and lots of viruses produce collagenase, the enzyme that breaks down collagen. Lots of viruses have epigenetic effects on the creation, that slows the creation of new collagen. Germs have had a lot of time to evolve and grow and develop and to get into that central nervous system that they love so much because it's protected. So they could hang out there for a long time. That's part of the reason why viral infections can make EDS and similar diseases and disorders worse.
so I might just touch on, just because it's a good segue, is about the etiology of ME/CFS then. Because we often see in the literature that ME/CFS, we see the words unknown etiology, yet we
Hmm.
also know it's often caused by a viral illness. But so what are some of your thoughts about other causes of ME/CFS?
Well, I think that there are a lot of disorders where we don't fully understand what causes them, but that isn't the same as unknown. We have a lot of pieces of the puzzle, but we need more pieces of the puzzle. So I often say that at least in terms of symptom presentation, there are three etiological buckets. The first of these is the damage that the original stressor did. So if this was a virus, you might end your viral infection in liver failure. It happens, right? That's something you have to address. There is the possibility, so that's bucket one, whatever damaged the pathogen or surgery or whatever it was that triggered your disease did is number one. Number two is the potential for a lingering pathogen or reactivating pathogen, like Epstein-Barr virus that causes mono, hangs out and reactivates. So does shingles, right? That's what causes shingles, I should say, is a reactivating herpes virus. And then you also have, these commensal bacteria and all these things in your body that used to just be hanging out. And if your immune system gets dysregulated, they can become a problem. So second bucket is we've actually got viruses still there. We've got new pathogens still hanging around because they're taking advantage of the opportunity of your messed up immune function. And then in the last bucket, which I think is the most important and least explored, is the immune, endocrine, and metabolic changes that are the host response to all of this. That's where a lot of the pathology is, in my estimation. And that's a lot of what we actually need to treat. Because if we do, we're not going to have any problem fighting off reactivated viruses and Candida or parvovirus B19, all these guys that like immunocompromised hosts.
Absolutely. And
By the
it
way,
seems to
personal
be.
ideas, right? There are like dozens of theories out there, but that's my personal take.
Oh, and I agree. I think that when we get down to the physiological malfunctions and dysregulation, and we figure out exactly what's going on and how to reverse or treat that, then that will be the key. And that's some of the work that here in New Zealand, Emeritus Professor Warren Tate is so hot on. Like that is what he wants to do. And I
That's
think
what I like to hear.
yeah, we seem to be. I think if there was a conference about 5 years ago where all the researchers were saying we're really close to therapeutic interventions. We're understanding more, and so I'm just waiting for that day when they can actually pinpoint and say,
I
yes,
think we're ready for therapeutic interventions. I think we don't have a cure, but that's not the same thing, right?
no,
There are
that's right.
plenty of things that a savvy medical professional can do right now to help patients. Shall I?
Do you want
Do
to?
we want to
Yeah,
go
do
into
you want to
that?
touch on that? Yes.
Sure. So we'll start with like the obvious. You need to pass pacing materials onto your patients so that they know how to manage their disease. I know everyone's waiting for the prescription drugs, so I'll say them right away. Low dose naltrexone has been shown to help a high percentage of people it's used on, particularly for sleep and pain. And I also think that pyridostigmine, also called Mestinon, which is used to treat myasthenia gravis, is another one where there are very few people I talk to who say it did not help them. It is a high percentage efficacy intervention. Now, you do have to find somebody who is willing to try that with you, but I will say that people with ME react to low doses of medications. So you're unlikely to have a clinician say, well, that's too high or that drug is too dangerous. Like in LDN, we're going with microdoses. And for most people with pyridostigmine, we're going with very, very low dose as well. I think those are the top two prescription medications that I think are have the greatest potential. Over the counter, higher dose CoQ10, as has been trialed in other neurological diseases. When I say high, I mean high. Omega-3s like DHA on its own or EPA plus DHA. There's people turn their noses up at non-pharmaceutical interventions, but this is a disease that the patient is going to be managing for the rest of their lives in most cases. And that means you go for the thing where effectiveness and safety are balanced very well. So for something like omega-3s, there's lots of evidence that they help with cognitive function. And they are foods. So they're relatively safe, generally recognized as safe. Lactoferrin in terms of making sure that the patient has iron without kicking off problems with the anemia of chronic illness. I wish we had more time to talk about that. We'll just have to skim past that, and I'll say I have a paper coming out that will describe that in more depth. Vitamin D, which patients are often quite low in, and B vitamins, which patients are also often very low in, but which are generally salutary in neurological diseases and disorders. There's lots of evidence for this. I mean, in terms of that, in terms of its efficacy in peripheral neuropathy, cognitive function, we could probably do the whole rest of the hour just on that.
Yeah, so here, and I'm not sure if it happens in the States, but here with Dr. Ros Valley, she always recommended B12 injections, even if the level might be 250 in the blood, and the GP is saying, no, you're fine, you're not deficient. And it's not really about deficiency, is it? To actually have injections and raise it up higher to sort of maybe into the 350 mark.
So, two things to say about that. We talked about how pacing was like the #1 rated intervention for patients. B12, both injectable and oral, made the top 20 as well. So lots of patients agree that it was helpful for them, and they rate injections as slightly more helpful than oral B12. That's #1. #2, there's no gold standard for measuring B12. I think that this is broadly misunderstood. You cannot count on, like, I think only 20% of people with deficient hollow cobalamin, which is the active form of B12, actually present with anemia. So, just saying, oh, well, if the red blood cell values get off, that's how we'll know if it's for sure happening. No, they won't necessarily. Just levels in the blood, nope, 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 nothing to do with the rate of metabolism. It's just, is it getting into your plasma? Which is pretty easy. It doesn't mean that the patient is utilizing it. Even MMA, methylmalonic acid, which a lot of people also think of as a gold standard, it does not necessarily correlate to the active form of B12 in the blood. So all of these are a little bit dicey. So if your doctor says, it just shows me in your blood that it's fine, well, yeah, you're probably taking 16 supplements because you're still getting like weird tingling in your fingers and you don't know what's up. Well, it's definitely worth a try to do B12. I'm not a doctor. This is not medical advice, as I always say. Obviously, if you have any reactions, stop doing it. But when I was sick, what my doctor told me, I went to a neurologist and he said, I don't think he knew about B12 not being able to be measured well either. He said, I don't know why, but my patients with chronic neurological conditions always need heaps of B vitamins. Keep taking it until you stop noticing additional benefit. And, stick at whatever dose that is. If it ever gets dangerously high, like we'll keep monitoring it and making sure it doesn't go through the roof. But provided it doesn't go too high, take as much as you want. And he was the neurologist and he had decades of experience. So this is what he had observed from working with patients and actually doing his best genuinely to help those patients.
That's great. And I think that's something we might be good to touch on, is that what people often find is they go to their GPs, and this is for GPs listening, that they're feeling like death. And then they get these routine blood tests done and they come back normal, and the GP says, "Ah, everything's fine, you're fine."
Mm-hmm.
And so, can you touch a little bit on what's going on in the research, which sort of demonstrates that those tests may be not showing deep enough what's actually happening in the ME body?
Sure. I will start by saying what is going to be obvious in retrospect, which is that there's no way that the 15 lab tests or the 10 lab tests you go get at the doctor cover every disease known to man. This is just simply not true. It's not even close to true. It investigates very little in the systems that affect people with ME most: immune, endocrine, metabolic, right? Even in some countries, they don't want to measure vitamin D. I was always amused by folks in the UK. I'm sorry, the UK, I love you. But the vitamin D level considered healthy is set so far below what it is in the US. And it's like, because people are just taking it from the median, and there's not a lot of sunlight in London. Shocker. So you do have to go, first of all, for what actually makes people feel healthy, not necessarily what is typical for your population. But beyond that, beyond those like obvious, like everyone knows to maybe second guess, that kind of thing. Studies that demonstrate dysfunction in ME/CFS include the 2-day cardiopulmonary exercise test. This demonstrates post-exertional malaise pretty well by having the person exercise to capacity on one day, wait 24 hours, and repeat. And what you should see is that, VO2 and work and all the things you measure in a normal cardiopulmonary exercise test are dramatically reduced in day 2 as opposed to day 1. If you happen to have been stressing and working your patient, it'll do it on the first exercise test because they're already in PEM. You'll see very abnormal values. When I got this done at Mayo in Rochester, I only had a 1-day test because they weren't doing 2-day. And the neurologist said, "You're perfectly normal if you were 82. I had just turned 30. So this, by the way, is different from other chronic illnesses. It's different from people who are deconditioned. And deconditioning people typically do a little better on day 2 than day 1, if not the same. But it is more common, as I understand it, to do better on the second day than the same. This is even different, according to one small study, than people who have just fatigue without PEM. So what we're seeing is something very unique there. But that's kind of like hard to put your patient through, isn't it? This is what we do in research in order to study the pathological state, right? As a doctor, you should be listening for things like, I try to do something and then the next day I feel like I'm full of concrete, I'm weighted down, I'm wearing a suit of armor. You should hear in mild patients, and you should stop them unless you want them to get worse, I work all week, I manage to get to the weekend, I sleep from Friday night through Sunday night. I get up to use the restroom and grab a meal bar. And if people keep pushing through that, they will become incapacitated and disabled. So post-exertional malaise is such an unusual experience that if you allow your patient to describe it and you listen carefully, first of all, you're not going to mistake it for fatigue. And second of all, you're going to know to give them a diagnosis of ME/CFS. And third of all, you're going to know not to treat them with more exertion.
Absolutely. And we often hear from people in the community that say that their health professionals don't actually get to see them at their worst simply because the patient is too ill to get to an appointment. And so we
Absolutely.
know, yeah, that there's this sort of spectrum of categories, and you've just touched on mild, and then we go up to very severe. Do you want to explain that severity to us?
Yeah, I want to, or will I? It's so heartbreaking, honestly.
Mm.
And for all of us who are moderate presenting, the early parts of the disease are a taste of what it's like to be severe presenting. Your world shrinks to your bed. People who are severe, have trouble with activities of daily living. They have trouble taking a shower, for example. They have trouble making a meal. They might get up and putter around their house, but they're unlikely to ever leave it. And once you get to very severe, we have, there are 2 or 3 researchers who study both AIDS, HIV, and ME/CFS, and they constantly compare very severe to late stage AIDS. Oftentimes there are profound digestive problems that can lead to literal starvation. The patient no longer has the digestive power to make use of food. Parenteral nutrition is therefore required. Their sensory sensitivity becomes so extreme that they cannot tolerate light, they cannot tolerate speech, they cannot tolerate the touch of a loved one. And these people are going through a kind of unimaginable suffering that goes on for decades at a time. You can die of this disease, but it's very rare. So that kind of suffering will go on for decades unless they improve, which again, they can. But it's very challenging once you've reached that stage of severity because everything becomes a stressor. It becomes very hard to climb out of the hole. That isn't to say I've never seen it done. I have.
That's good. That's some hope because we've been dealing with people who are severely ill at the moment in hospital for the past few months, and it is heartbreaking to see them. You know, they have lost everything and are confined to beds and require care. They're no longer independently able to feed, toilet, bathe themselves. And it is horrific for them and for family who inevitably become their full-time carers. And I'm glad that you touched on the gastrointestinal issues that go on there and the literal starvation, because what we're finding is that health professionals are missing that connection between what's going on with ME/CFS and severe autonomic dysfunction. And that is what's
Yes,
creating this
yes.
gastrointestinal issues, right?
So there's
You
poor innervation to the gut, and then that slows digestion, and people develop what we call gastroparesis and potentially SIBO, because the slower digestion moves, the more likely bacteria and fungi are to grow in the gut and then grow up through the digestive system, which is what SIBO essentially is. Um, I would say that if clinicians are listening and they have a patient who's mild or moderate and they don't want them to get worse, digestion is the thing to watch. Um, it's not just that it's the canary in the coal mine. I would even say dizziness is the canary in the coal mine. That's often the first symptom that people begin experiencing. Digestion is the thing that if you let it go and let it get worse, that's what leads to severe presentation, in my estimation. If you cannot digest your food, you cannot digest your medications, you cannot get better. So it's very important. Digestion first, digestion last, digestion always.
That's right, and that's why it's so important to consider those alternatives like nasal gastric tubing and things like that to actually just get nutrition and sustenance into a body because we all know nutrition is fuel. It is the energy for
It's what
which
all of our
bodies
cells
can
need to keep
function.
working. Yeah.
Exactly. So if people are not getting their calorie intake,
Mm.
find ways to make that happen. Another thing a common response that we are experiencing from medical teams is that the condition is psychological or factitious. So, how would you respond to that?
I'm surprised you even repeated that. I think that that generally is an excuse a provider makes when they're unable to help the patient. I don't think that there is much truth to that. The CDC did a study a while back that compared social role functioning, emotional role functioning. There's not really any difference between people with ME and other groups. But I do think that it's very convenient for lazy clinicians. If you don't want to take the time dealing with a complex patient, bounce them to psych. Then you don't have to deal with them anymore. They're not your problem. And it's very disappointing when there's so many things that you can do to help. But the information is not being taught maybe at their medical school. Maybe their mentor is like old school, didn't learn anything about these diseases. And of course, if they don't know it, it can't be important. So that dismissiveness gets passed on to the next generation of clinicians. This was never acceptable, right? But we know so much more than we did in the late 80s, early 90s when these diseases were first beginning to be known, that there's genuinely no excuse for that anymore. Now, if somebody is experiencing the grief that you live through when you become disabled, and you're losing friends, and maybe you've lost your job that you felt to find you, that's different. Of course you need counseling for your grief, for what you're going through. And I think that anybody who is experiencing those feelings should get the help that they want and need. And I also think that it is common for, people to have depression in general. In the United States, it's they think depression or anxiety is 1 out of 2 people. So there's a decent chance that you have depression as a comorbidity just as often as somebody with any other disease does. And in that case, it needs to be treated very carefully because a lot of psychotherapeutic medications have immunological effects. You have to be very cautious.
That's right. And you really touched on the psychosocial impacts of living with long-term condition. There is this grief process. And so why is it so important for people with this condition to actually manage stressors in their life?
Well, if people have trouble regulating autonomic things like your heart rate, if you get startled and your autonomic nervous system is dysregulated, long after that mild jump scare is gone, the person's heart can continue pounding. Um, People with POTS in particular, I remember hearing at the Dysautonomia International Conference that they process adrenaline very slowly. So it stays in their system longer than it does for other people. So emotional stressors are still stressors and they can still precipitate PEM. I also remember at the very first Stanford conference, me and a bunch of patients were talking about how you had to learn to be a Zen master when you got this disease. And everything must be chill and nothing may upset you. And obviously that's not, real life, but we do our best because regulating your emotional responses is kind of part of pacing.
Absolutely. And that might be a nice segue into actually just talking about the disease management again around pacing. Um, for children in particular, so are there adjustments that they might need at school to help with that?
Absolutely. So if you are a teacher who tends to give 4 worksheets to practice a skill, you might want to decrease that number for your child with ME/CFS, or any other fatiguing conditions. So like decreasing the amount of work. There can be, for people with sensory sensitivities, they might be asked, the teacher might be asked to allow noise canceling headphones in class when work is being done. So all of those sensory accommodations, if it is at all possible, being able to complete schoolwork and or attend classes via Zoom from home for children who are very ill, excuses from gym, for example. I think I think that it's really challenging for people to understand how more exercise isn't good for everybody, and that includes the gym teachers. I do think it's important for people with ME to be as active as they can in a way that doesn't induce PEM. Sedentary isn't great either. It's not great for your circulation. It's not great for your digestion. So it may be for classes like gym, you allow the child to move around until they get that first hint of feeling uncomfortable, and then they go sit for a while. All of these things can be accommodated, and Ask Jan has ME/CFS accommodations on its site, and also the pacing guide for children with long COVID and ME/CFS also includes some accommodations for school.
And you touched on earlier that recovery might be more common in children, but they could potentially relapse in adulthood. So they need to really focus on PEM and pacing. But it's not always the case, is it, that children recover? For some,
Oh, no.
that
No, absolutely not. Recovery is rare in both cases. There are just a few studies that make it appear as though it's slightly more common in children.
and if we go back just briefly to sort of historical interventions, maybe we can touch back on that sort of psychosocial aspects as well. What are some of the historical interventions, and why did they change? Why is the thinking different now?
That's a great question. And a lovely way to discuss a discredited therapy. People used to try to gradually increase exercise in people with ME, under the belief that this would cure them. There are so many things wrong with this, but I want to start with like a broader thing. Even if you're healthy, take a moment to think about what you would do if you began to get like more fatigue than usual and maybe experienced a little weird payback after doing too much. Have you got it? What would you do? Would you start exercising, but only a little at a time? Yes, you would. You know you would, because that is the common sense thing to try. What does that mean? Every patient has tried it for themselves. If it doesn't work, when the patient does it, what magical ability does the clinician have to prescribe activity in precisely the right amount for that person, and guide them into increasing it over time? It also implies that people used to believe that it was just deconditioning, which is, again, the 2-day cPET means that that's not true. There are also so many metabolic irregularities that results when patients exercise. It's not just the VO2 and the things you measure on a cPET. It is also our cellular bioenergetics. The way that we get energy from food is very messed up. And it's all messed up in the same way on average if you take a sample of patients as in other studies. So we've seen this again and again. The way we break down sugar in particular is very messed up. So obviously what this did is it made patients more debilitated over time. In patients where it did not, there is some evidence that what patients would do is that they would show up to the clinician's appointment, do all of the prescribed exercises, go home and collapse, and recover until the next time. Oftentimes this was coupled with cognitive behavioral therapy where patients were encouraged to ignore their symptoms. So in practice, what would happen is that there would be training on if you acknowledge that you are a sick person and you don't ignore your symptoms, you will get worse. And then at the end, they will say, "Are you a sick person?" And of course, you would have to say, "No, no, no, like I'm well, I'm better now." So these interventions appeared effective at first, but every follow-up that's ever been done shows no improvement anymore, a null result. And as someone who's worked in advocacy for 10 years, I can tell you that every time we do a poll about these interventions, they emerge as incredibly harmful. People who could walk around but weren't very physically active, requiring a mobility device after going through these programs, people who generally used a mobility device to go longer distances becoming bedbound. I know that there are still people who think exercise is the answer. It's ableist. There are always going to be people who just deeply wish to believe, because this would make the world feel safer to them, that if they got chronically ill or someone that they loved did, that there would be something simple and common sense that they could do that would fix everything. And the real reason it hasn't fixed everything for these other sick people is that they simply aren't as enlightened and determined and full of fortitude as they are. That's ableism. People aren't sick because of the choices they've made. Sometimes people just get sick. And sometimes they can't fight or fortitude or think their way free. And
Wow.
implying otherwise is really insulting, actually.
Absolutely. And thank you so much. It's a great place to end. But I just thought if you have any final messages that you might want to provide to healthcare providers who want to learn about ME/CFS, or suspect that one of their patients has ME/CFS, what would you say?
Well, I am possibly biased, but I'm very fond of the Mayo Clinic Proceedings article I co-authored with Mayo Clinic researcher clinicians, Tony Chan, Stephanie Grach, and Ravi Ganesh, all brilliant people. Together, we wrote a concise clinical review. It's very short. It's a great introduction to the disease. You'll learn what you have to know to diagnose patients there. And you'll see some really good intervention recommendations beyond what I've mentioned here. And there's a continuing medical education. It may not be active in your country, depending on where you're listening from, but you can still answer the questions and test yourself. If you're a medical student listening to this, ME Action created an Anki deck, which is used to study in medical school for infection-associated chronic conditions, and it's now recommended by the CDC, so you know it's decent quality. And I think that the pacing guides are really valuable as well, honestly. A lot of people say that that's how they learned about pacing, and a lot of people, as we know, say pacing is really effective for them. And above all, find your community. There is a group where you live. It's really important to know that you're not alone and to be with a group of people who get it. And to anybody who's listening who has any funding, fund ME/CFS. It is going to be the next great scientific discovery when we learn exactly what causes this and exactly how to prevent and treat it. And you can be part of that.
That's excellent. Thank you so much. I really appreciate your time today. I know it's an incredibly busy time with preparation for
There
World ME
is.
Day, but thank you so much for joining us, and all your insights have been highly valuable. So I appreciate your time. Thank you.
Thank you, Fiona. And thanks everybody for listening.